Hi everyone. Today I am going to talk about diabetic neuropathy, an important condition especially for the patients who are having a long-standing diabetes. Now, just to have a basic introduction, diabetic neuropathy is a syndrome which is comprising of a disorder that is having a distinct component of peripheral nervous system. So it is not just one disease, it is a kind of a syndrome which involves the multiple components of peripheral nervous system like sensory, somatic, motor as well as autonomic nervous system. As per the IDF, that is International Diabetic Federation, estimates that about 73 million people have diabetes and about 133 million people have pre-diabetes in India. So it is a very significant problem of a very high magnitude. And diabetic neuropathy is highly prevalent complication that affects the quality of life of the patient. Now, prevalence of neuropathy is around 8 to 50% depending on various multiple factors, and usually the prevalence is similar in both type 1 as well as type 2 diabetes. Now, if we include the asymptomatic patients of neuropathy, then the incidence or prevalence appears to be higher to the tune of 45 to 54% in type 2 and type 1 diabetes. Now, the various risk factors of diabetic neuropathy involves hyperglycemia, that is blood sugar level, high blood sugar level, the duration of diabetes. Now, this is an important aspect, that longer the diabetes, the risk of neuropathy is higher. The older patient, the smoking habits, alcohol abuse, hypertension, obesity, and dyslipidemia. So all these are the risk factors in the patients who are suffering from diabetic neuropathy. Now, coming to the pathogenesis, briefly about how does it develop and why it happens. The most important cause of diabetic neuropathy is oxidative stress. There is a formation of free radicals because of hyperglycemia. There is formation of multiple free radicals which are interacting with the various tissue proteins and the enzymes. Like one is called aldose reductase, which is very, very important. And there is a high activity of aldose reductase in the patient with diabetes. There is a glycation of protein. Because of hyperglycemia, the glucose directly interact with the tissue protein, causing formation of various products or degradation product. The activation of protein kinase, the nerve hypoxia and ischemia, and decreased essential fatty acids. And all these leads to defective or impaired myelination of the nerves, leading to development of neuropathy. Now, coming to the molecular level, or slightly going into the detail, the diabetic neuropathy, if we see, there is a pathological alteration in the neurons, the glial cells, and the vascular cells. There is a DNA damage, there is a dysfunction of the mitochondria, endoplasmic reticulum. There is a loss of neurotrophic signaling, so the formation of nerve factors are compromised. And also there is activation of macrophages. So you can see that there are multiple mechanisms which are working together to derange the nerve in the patient who is suffering from diabetes. Now, the staging of diabetes is done. A diabetic neuropathy has got 4 different stages depending on the category or depending on the severity of the disease. N0 is just no symptom and sign of neuropathy. In N1, the patient has got no symptoms, but there are few signs of neuropathy. There may be loss of sensation. There could be some alteration of the reflexes. There could be some changes into the nerve conduction velocity, etc. But patient does not have any symptoms. That is N1. N2 is primarily the symptomatic neuropathy, where there are symptoms, which we will see just now, and so it becomes N2. And N3 is a disabling polyneuropathy, which compromises the function of the patient as well as the quality of life. Now, this is an important point to neuropathy and impaired glucose tolerance test, because normally we associate neuropathy only with the frank diabetes if the patient has got hyperglycemia. But even patients who are not having high blood sugar level, but if they are having something called impaired glucose tolerance, or if they have, you can say, in the range of pre-diabetes, even then they also can have the feature of neuropathy. And it is seen that patients who have got neuropathy, the impaired glucose tolerance to the tune of 25 to 35%. So significant number of patients of neuropathy, they will show the impaired glucose tolerance. So it is important that if there is a diagnosis of neuropathy, or if the patient has got painful neuropathy, the glucose tolerance test is one of the important investigation to rule out the impaired glucose tolerance test or impending diabetes. Now, the painful diabetic neuropathy, about 30 to 50% of the patient with diabetic neuropathy develop neuropathic pain. Pain is a complex interplay between multiple factors, so the severity of pain or the perception of pain can be variable in different patients. And this pain is depending on the genetic factors, the psychological factors, somatosensory factors, and so many other factors, including the severity of neuropathy. What is the extent of damage? Even that also can be deciding for the pain sensation. The risk factors for painful neuropathy includes the female gender, the poor glycemic control, impaired kidney dysfunction, and high BMI, and the people who are obese. So the point important to note here is that all the neuropathic patient may not have a significant pain. The patient may have a neuropathy, there may be, you will find the sign of neuropathy, which is like sensation, loss of sensation, there could be a disturbance in the reflexes, and so many other factors, but he may not have pain. Whereas 30 to 50% of the patient may have a significant pain, and then you come to know that he has got a diabetic neuropathy. So this is important to note that pain, though it is an interplay of multiple factors, may not be present in all the patients of diabetic neuropathy. Now, this is one very characteristic and you can say a pathognomic feature of diabetic neuropathy, which is distal symmetrical sensoromotor polyneuropathy. Now, this is most common in diabetic neuropathy. Distal, it is actually involving the distal part of the body. It is on both the sides, with both the limbs or both the hands. And it is a mixed kind where there is a sensory disturbance, there is an autonomic disturbance, and there is a motor involvement of the various combinations. And mostly it is diagnosed if you find other diabetic complication like nephropathy and retinopathy. So if you see one complication of diabetes, say diabetic nephropathy or neuropathy, then you please find out other complication which may arise at the same time in the same patient. In the presence of autonomic dysfunction, distal symmetrical neuropathy is almost invariably present. And the patient of long-standing diabetes may have autonomic neuropathy in like gastroparesis, they may have bladder dysfunction, they may have erectile dysfunction. So all these are autonomic dysfunction which are found in patients with diabetes, long-standing diabetes because of nervous dysfunction. And in such cases, usually the symmetrical neuropathy is most of the time present. Usual symptom of diabetic neuropathy is feeling of numbness. There could be a sharp shooting or stabbing pain. There could be dull pain or dull constant pain. There could be tingling sensation of pins and needles. There could be sensation of hot and cold. And important point is that some of these patients, they can feel allodynia. Allodynia is basically the pain which can trigger or which is triggered by a very trivial stimulus like covering the body with a blanket may cause significant pain. So there's a very hyperexcitability of the nerves. The nerves are hypersensitive, they are very hyperexcitable. So even the minimal stimulus, just touching the part, can even trigger the pain sensation. The sign of diabetic neuropathy is essentially weakness, which is in the distal area. There could be sensory loss commonly seen in the feet and toes, absence of ankle reflexes, loss of vibration sense, and sensory loss extend proximally to the fingertips. Now, some of the investigation which are advisable to be conducted if the patient comes with the clinical features of diabetic neuropathy. One is, of course, blood sugar estimation, the HbA1c, also the urine analysis for glucose, protein, and microscopy to rule out if there is any feature of nephropathy or impending nephropathy in the patient. Serum urea, serum electrolytes, thyroid function, liver function, and not to forget serum vitamin B12 in such patients who are having the symptom of neuropathy. Now, these are some of the electrophysiological tests which are done not on the routine basis. They are mostly done for academic interest, are primarily done in the research settings. They may not give very specific information for the diagnosis of diabetic neuropathy, but they may give some additional information if you conduct the test like nerve conduction study, nerve conduction velocity, what we call NCV, electromyography, etc., microneurography. Some of these tests are used are in very specialized center, and primarily they are done if the patient is either not diagnosed properly, or maybe if he is not responding to the treatment, and then to find out slightly more in detail about the status of neuropathy, then it can be done. The treatment of neuropathy is to be directed for correction of the underlying pathogenesis, like control of glycemia. This is important, that blood sugar should be controlled tightly. Patients should be given antioxidant therapy in some form or the other, because the free radicals are one of the major factor in causation of diabetes or in the genesis of diabetic neuropathy. So antioxidant therapy should always be given. There are few mention of aldose reductase inhibitors. Some of the drugs, they have been developed and tried, but somehow they did not qualify for the efficacy, and the clinical trial failed to show any benefit of these drugs. So practically they are not used in the clinical settings. Patients should also be advised to use proper footwear for the foot care to avoid any further trauma to the foot, so that he should not develop any complication in future, and physiotherapy. So all these are supportive measures for the patient of diabetic neuropathy to control the symptom and control the problems. Now, coming to the drug treatment is firstly, the most commonly which is given in the initial stages are NSAIDs, that is normal painkillers, all drugs which are given. Most of the time these drugs are not very effective, and we have to go to the next level of treatment, which are primarily in form of antidepressants or anticonvulsant medicines, which are specifically used for the treatment of diabetic neuropathy. There are topical creams containing capsaicin. Capsaicin is also one of the substance which has got analgesic effect by acting on a particular receptor, and it is used in form of a cream. So this is found to be effective in certain cases. And lastly, opiates, also as an adjunct therapy for the treatment of diabetic neuropathy. Now, in the antidepressant category, there are two main categories which are used for diabetic neuropathy. One is tricyclic antidepressants. We have seen them in the earlier presentations. Primarily two drugs, there is amitriptyline and nortriptyline. They are the commonly used drugs for diabetic neuropathy. Both are of the same class of the drug, more or less the same. In fact, nortriptyline is a metabolite of amitriptyline, but the advantage of nortriptyline is that nortriptyline does not have anticholinergic effect as compared to amitriptyline. So it is slightly safer, you can say. So any of these two drugs are used. Then SNRIs can be used, selective noradrenergic reuptake inhibitors like duloxetine or venlafaxine. And among these two, in fact, the physician preference is mostly duloxetine because of its few more effects other than pain relief in the diabetic neuropathic pain. The clinical efficacy is more or less the same among the class, and using these antidepressant in neuropathy have an added advantage to take care of the coexisting depression, because most of these patients who are having neuropathy, it's a chronic problem. They have some kind of insomnia, the disturbance in the sleep. They have even anxiety. They have depression. So giving such drugs like duloxetine or even amitriptyline or nortriptyline, they help to take care of those coexisting problems as well. And as per the international guidelines, both tricyclics and SNRIs are recommended as the first-line therapy in diabetic neuropathy. Another class of drug which is used in diabetic neuropathy is anticonvulsant. Of course, not all the drugs. Three main drugs which are used are pregabalin, gabapentin, and carbamazepine, which are used for neuropathic pain. Pregabalin and gabapentin, they are almost the same class of drug. We characterize them, we call them as gabapentinoids, and they are recommended as a first-line therapy for diabetic neuropathy. And these drugs, that is pregabalin or gabapentin, can be used as a single drug, or they can be used in combination with tricyclic antidepressants. The dose of pregabalin is in the range of 75 to 300 milligrams per day. The gabapentin is to be given at minimum 900 to the max of 3600 milligram per day. So depending on the patient tolerance and its convenience. The important point about the treatment in neuropathy is generally monotherapy is not very successful. In majority of the patient, they do not respond to single medicine, or even if they respond to single drug, over a period of time they stop responding to a single drug, whether you give antidepressants or you give anticonvulsants. So majority of the time we have to rely on combination therapy, where we combine two class of the drugs, maybe antidepressant with anticonvulsant, like that. And to have more effects or better effects, the combination therapy is given. The American Diabetic Association endorses a combination approach of first-line medication for patient requiring intensification of therapies. So as we have seen, at one side, the TCAs and SNRIs are the first-line therapies. On the other side, gabapentinoids, that is pregabalin and gabapentin, is the first line of therapies. So combination of any of these two classes of drug will be recommended for those patients who have not responded to monotherapy or who requires enhancement of therapies. Now, the gabapentin plus nortriptyline, the trial published in Lancet, it was a double-blind trial which has shown that the combination of gabapentin plus nortriptyline is much effective than a single drug of gabapentin and nortriptyline. In a Cochrane review, which had included about 21 randomized clinical trials of various combination drug for neuropathy, like opium with pregabalin or gabapentin, opiate with tricyclics, gabapentin plus nortriptyline, tramadol plus paracetamol, and all these studies, which is of good quality studies, they have shown that combining two drugs has got a better efficacy in most of the cases. And the meta-analysis has shown that opiate plus gabapentin is of course a good combination, but somehow opiate always had a high frequency of adverse effects. So this particular paper, though of course suggests opiate as also one of the therapy, but on the long-term basis, there was a lot of discontinuation by the patient because of high frequency of adverse effects. One of the very recent trial published in August 2022 in the Lancet is Option DM trial, which again talks about the treatment of neuropathy with a combination. And here they have used pregabalin, gabapentin with or without amitriptyline. And they again recommend that combination therapy was well tolerated and it has led to significantly better pain relief than a single drug. So the message is that whenever we are having a patient of diabetic neuropathy, we may start with a single drug if the patient is not having acute pain or the patient is not having very severe pain, but eventually we may have to come to the combination therapy in the long run. The fixed dose combination, and because of this combination aspect, the fixed dose combination are there. They have additive or synergistic effects. They reduce the polypharmacy. They allow the lower drug dose of the individual drugs and thus minimizes the side effects. The better patient compliance because of single drug, a single tablet. There is more patient adherence, mainly in Indian settings, because here the compliance is usually poor. So if you have a fixed dose combination, the drug is taken by the patient much conveniently. And combination of gabapentinoid and tricyclic may be a good acceptable option in good number of cases. Now, even after giving the combination, patient may not respond to treatment of with these drugs in neuropathic pain. And for such cases, some of the options which are tried is intravenous lidocaine, which is a local anesthetic drug, the combination of tramadol or tapentadol, local nerve blocks, and TENS, that is trans-electrical nerve stimulation, and acupuncture. So some of these methods are used for the treatment of neuropathic pain which do not respond to the conventional treatment by the drug. Now, the important question is when to refer the patient. If when to refer means when to a specialist, means a neurologist or the person who is expert in the pain management, especially if the patient do not respond to two drugs of different classes. You may try combination, but patient is not responding. The long-standing neuropathic pain, suspected polyneuropathy, significant sensory or motor disturbances, and if the patient has got contraindication to the first-line treatment. So some of these are the conditions where you recommend, or we recommend, to refer to the patient to the next expert level. Thank you.